What's up, my average med students? Welcome back to another episode. Today we're going to be covering palm crit from the TZANKI Step 2 deck. If you haven't already done so, please hit the subscribe button and press the bell icon to be notified of future posts. Happy studying.
1. For a patient on a ventilator, what is the best way to correct low partial CO2? Decreasing respiratory rate or tidal volume is more efficient to change. 2. A patient with ARDS is placed on CPAP after intubation. Shortly after, he develops hypotension. A medical student noticed tracheal deviation to the left during rounds. What test should be ordered to confirm the most likely diagnosis? Chest X-ray to diagnose tension pneumothorax. Complications of CPAP include barotrauma, which typically involves worsening shortness of breath after CPAP has been given to the patient. You can suspect pneumothorax if the patient becomes hypotensive and mediastinal shift or tracheal deviation. Diagnosed with chest X-ray, treatment is with needle decompression, can be secondary to barotrauma. 3. What ECG findings are classically associated with pulmonary embolism? S1Q3T3 or right heart strain, depression and T-wave inversion in the right leads AV-R, 2, V5 and V6. This is rarely seen. Sinus tachy is the most common. S1Q3T3 prominent S in lead 1, Q-wave in lead 3, T-wave inversion in lead 3, indicative of right heart strain. 4. A patient is thought to have a pulmonary embolism but cannot tolerate IV contrast due to severe renal disease. What other diagnostic tests can be ordered to help in the workup? Q-scan. 5. Patients with adult-onset asthma and symptoms that are worse after meals, exercise, or laying down are likely to have GERD as a primary trigger. When suspected, a trial of PPIs can be both diagnostic and therapeutic. Mechanisms by which GERD exacerbates asthma. 1. Increased vagal tone. 2. Heightened bronchial reactivity. 3. Microaspiration of gastric contents into the upper airway. 6. A patient presents with fever, cough, night sweats, weight loss, and hemoptysis. He has risk factors for TB. You suspect TB. A chest X-ray is positive. Follow-up acid-fast bacillus smear is also positive. What is the most appropriate next step in management? This is a diagnosis of active TB. The usual first-line treatment involves taking a combination of isoniazid and rifampin for a period of 6 months, along with ethambutol and pyrazinamide for the first 2 months of treatment as per Amboss. 7. A patient presents with fever, cough, night sweats, weight loss, and hemoptysis. He has risk factors for TB. You suspect TB. A chest X-ray is positive. Follow-up acid-fast bacillus smear is negative. What is the most appropriate next step in management? Isoniazid for 9 months. Collect early morning sputum and get at least 3 cultures 8 hours apart. To help ensure a true result, get 3 early morning sputums 24 HRS apart. Your last-ditch effort, if you have a very high suspicion of TB, is nucleic acid assay. 8. Ventilator support settings. 1. When the partial oxygen concentration is too low, the settings on the ventilator should be adjusted to increase the fractional inspired oxygen or the positive end expiratory pressure. 2. If the partial oxygen concentration is too high, the settings on the ventilator should be adjusted to decrease the FiO2 or PEEP to prevent free radical damage. 3. If the partial pressure of carbon dioxide is too low, the settings on the ventilator should be adjusted to decrease the tidal volume or respiratory rate. 4. If the PaCO2 is too high, the settings on the ventilator should be adjusted to increase the tidal volume or respiratory rate. 9. Adverse effects of non-selective beta blockers include exacerbation of asthma and COPD. Adverse effects of non-selective beta blockers include exacerbation of asthma and COPD due to beta antagonism. 10. Are lung adenocarcinomas typically centrally or peripherally located? Peripherally. 11. What is the test of choice to diagnose pulmonary embolism in clinically stable patients with a high likelihood of modified Wells greater than 4? CT angiography is the preferred test for diagnosing pulmonary embolism in stable patients with a high likelihood of the condition modified Wells score greater than 4. D-dimer testing can help rule out pulmonary embolism in patients with a low likelihood of the condition. Other tests, such as duplex ultrasonography or ventilation perfusion scanning, may also be used to evaluate patients for pulmonary embolism. 12. What is the next step in management for a patient with severe asthma exacerbation with an elevated PaCO2? Endotracheal intubation patients with asthma exacerbation often have tachypnea, which should lead to low CO2. A normal or elevated partial CO2 suggests impending respiratory failure, inability to meet increased respiratory demands. 13. What is the best test to differentiate asthma from COPD? Spirometry before and after an inhaled bronchodilator. Reversal of airway obstruction suggests asthma. Partial or non-reversal suggests COPD. 14. What is the likely diagnosis in a young man with an anterior mediastinal mass and elevated beta-HCG or alpha-fetoprotein? Non-seminomatous germ cell tumor. 15. Transudative pleural effusions are characterized by lesser than 0.5 low pleural serum protein ratio. 16. What is the recommended anticoagulation for pulmonary embolism in a patient with severe renal insufficiency GFR lesser than 30 ml per minute divided by 1.73 meters? Unfractionated heparin followed by warfarin. Low molecular weight heparin and factor Xa inhibitors are not recommended in renal insufficiency because they are metabolized by the kidney. Warfarin is preferred long-term oral anticoagulant in ESRD patients, but needs to be bridged first. 17. What is the initial treatment of choice in asymptomatic or mildly symptomatic patients with SIADH? Fluid restriction plus or minus salt tablets. 18. What is the recommended treatment for patients with SIADH who have severe hyponatremia, for example, seizures, coma? Hypertonic 3% saline. 19. What is the likely diagnosis in a patient with significant smoking history who presents with shoulder pain, weight loss, and the imaging findings below? Panco's superior sulcus tumor. Other common manifestations are Horner syndrome, C8 to T2 neurological involvement, and SVC syndrome. 20. Patients with COPD and signs of right heart failure or hematocrit greater than 55% should be started on long-term home oxygen if partial O2 lesser than 59 mmHg or saturated O2 lesser than 89%. Has been shown to prolong survival and improve quality of life. Resting partial O2 lesser than 55 or saturated O2 lesser than 88 if no evidence of right heart failure or hematocrit lesser than 55. 21. What is the likely underlying etiology in a patient with bronchitis predominantly in the upper lobe and sputum cultures positive for Pseudomonas aeruginosa? Cystic fibrosis. 22. Is smoking cessation associated with a mortality benefit in patients with COPD? Yes, decreased mortality and reduced progression of disease. 23. What is the likely diagnosis in a patient with sinusitis, lung nodules, cavitations, and elevated creatinine? Granulomatosis with polyangiitis, formerly Wegener's, upper and lower respiratory tract granulomatous inflammation and glomerulonephritis. 24. What autoantibody is classically elevated in granulomatosis with polyangiitis? ANCA, typically CANCA, proteinase. TZANKI aids with diagnosis, definitive diagnosis made with tissue biopsy showing granulomatous inflammation, formerly known as Wegener's. 25. What regions of the lung are most commonly involved in supine patients with aspiration pneumonia? Posterior segments of upper lobe and superior segments of lower lobe. 26. What is the likely diagnosis in a patient with respiratory distress, hypoxemia, and diffuse, bilateral alveolar infiltrates not due to CHF fluid overload? Acute respiratory distress syndrome. 27. How does the partial O2-FiO2 ratio change in patients with ARDS? Decrease lesser than 300 mmHg. Partial O2 decreases and leads to an increased fractional inspired O2 requirement. Lower PF values indicate more severe ARDS. 28. What is the likely diagnosis in a patient with an extensive smoking history who presents with digital clubbing and sudden onset arthropathy of the hand or wrist? Hypertrophic osteoarthropathy, often associated with lung cancer, therefore chest X-ray is indicated to rule out malignancy or other lung pathology. Most common causes are lung malignancies, cystic fibrosis, and right-to-left cardiac shunts. 29. What is the likely diagnosis in a patient on a ventilator who develops hypotension, tachycardia, and unilateral absence of breath sounds? Pneumothorax due to positive pressure ventilation. Hypotension and tachycardia result from impaired right ventricular filling secondary to compression of the IVC. 30. What is the likely diagnosis in a patient with COPD who presents with JVD, hepatomegaly, and pitting edema? Cor pulmonale, for example, right heart failure from pulmonary hypertension. 31. What is the likely diagnosis in a patient with a recent uria and a persistent productive cough with blood-tinged sputum without fever or significant chest X-ray findings? Acute bronchitis, pulmonary airway disease, chronic bronchitis, bronchogenic carcinoma. Bronchitis is the most common cause of hemoptysis in adults. Treatment is supportive. 32. What is the recommended management for symptomatic acute bronchitis? In SIADH, bronchodilators, symptomatic treatment. Antibiotics are not recommended. May see small amounts of hemoptysis due to inflammation and epithelial damage. 33. How does residual volume, FRC, and total lung capacity change with obstructive lung disease like COPD? Decreased elasticity of alveoli results in decreased collapsing pressure, thus alveoli retain more air trapping. 34. What is the likely diagnosis in an obese patient with daytime hypercapnia, hypoxemia, and respiratory acidosis? Obesity hypoventilation syndrome, defined by obesity BMI greater than 30, daytime hypercapnia PaCO2 greater than 45, and alveolar hypoventilation. Pickwickian syndrome. 35. What is the most common trigger of acute COPD exacerbation? Upper respiratory infection. Your examination often reveals wheezes, tachypnea, prolonged expiration, and use of accessory muscles. 36. What is the likely diagnosis in an immunocompromised patient with fever, chest pain, hemoptysis, and pulmonary nodules with ground glass opacities on CT scan? Invasive aspergillosis, triad of fever, CP, hemoptysis, and immunocompromised. 37. What is the next step in management for a solitary pulmonary nodule discovered on routine chest X-ray? Review previous chest X-ray. 38. What is the likely diagnosis in a young patient with minimal smoking history who presents with progressive dyspnea, cough, and bilateral basilar hyperlucency on chest X-ray? Alpha-1 antitrypsin deficiency classically presents with panicin emphysema that results in greater destruction of the lower lobes, also is associated with liver disease. 39. Pleural effusion and atelectasias result in decreased breath sounds, decreased tactile fremitus, and dullness to percussion. Fluid is present outside the lung in the thoracic cavity, which insulates breath sounds and vibration, fremitus originating within the lung. 40. What is the likely diagnosis in a young male with hemoptysis and hematuria without history of sinusitis? Goodpasture's disease, granulomatosis with polyangiitis can cause hemoptysis and hematuria with upper airway involvement, for example, sinusitis, otitis media, etc. 41. Restrictive lung disease is characterized by an FEV1 divided by FVC ratio greater than 70% of predicted. However, the individual values for both FEV1 and FVC are decreased. 42. All patients with acute COPD exacerbation should receive inhaled bronchodilators and systemic corticosteroids. Supplemental O2, antibiotics, and ventilatory support should be administered when indicated. Bronchodilators include anticholinergic ipratropium, tiotropium, and beta agonists. 43. In mechanically ventilated patients, plateau pressure is equal to the sum of elastic pressure plus expiratory pressure. Measured during an inspiratory hold maneuver, elastic pressure is a measure of tidal volume divided by compliance. 44. Interstitial lung disease is characterized by a low DLCO. 48. What is the likely diagnosis in a patient who develops respiratory failure, hypotension, and DIC immediately postpartum? Amniotic fluid embolism. 49. What chest X-ray finding is characteristic of epiglottitis? Thumbprint sign enlarged epiglottis on lateral neck X-ray. 50. Extrinsic causes of restrictive lung disease are characterized by a normal DLCO. For example, myasthenia gravis, ALS. 51. What is the likely diagnosis in a patient with sudden onset pleuritic chest pain, hemoptysis, dyspnea, and the CT findings below? Pulmonary embolism chest CT scan showing a wedge-shaped infarction. Virtually pathognomonic for Hampton's hump. 52. What type of pleural effusion, transudative or exudative, is commonly seen with pneumonia, for example, parapneumonic effusion? Exudative. 53. What is the likely diagnosis in a patient with mild hypoxemia, tachypnea, and chest X-ray infiltrates hours after an episode of aspiration? Aspiration pneumonitis. Gastric acid induces a chemical burn with a consequent inflammatory response, resolves with supportive management. Treatment is supportive. 54. Which part of the mediastinum anterior, middle, posterior are bronchogenic cysts usually found? Middle mediastinum bifurcation of the trachea occurs in the middle mediastinum, so the bronchi are obviously located in the middle mediastinum. Other middle mediastinal masses include tracheal tumors, pericardial cysts, lymphoma, lymph node enlargement, and aortic aneurysms of the arch 1 anterior mediastinum. 4 T's: thymoma, thyroid neoplasm, teratoma, terrible lymphoma, middle mediastinum, bronchogenic cyst, tracheal tumor, pericardial cyst, lymphoma, lymph node enlargement, aortic arch aneurysm. 3 posterior mediastinum, meningocele, enteric cyst, lymphoma, diaphragmatic hernia, esophageal tumor, aortic aneurysm. 55. The diagnosis of asthma can be made in patients with normal or increased DLCO and a greater than 12% increase in FEV1 following bronchodilator administration. Patients with COPD typically have a decreased DLCO and lesser than 12% increase in FEV1 after bronchodilators. 56. Which type of lung cancer is associated with hypercalcemia ectopic PTHrP production? Squamous cell carcinoma. 57. What is the underlying etiology in a patient with severe COPD who develops altered consciousness and seizures after administration of supplemental O2? O2-induced CO2 retention. Normal respiratory drive regulated by CO2. COPD patients have chronic failure, so are accustomed to high CO2. Thus, in COPD, reduction of O2 equals trigger of respiratory drive. O2 equals loss of trigger equals reduced RR equals CO2 retention equals hypercapnia. Patients have a decreased respiratory drive and loss of compensatory vasoconstriction. 58. What is the likely cause of dyspnea in patients with ankylosing spondylitis? Limited chest and spinal mobility causes a restrictive pattern on PFTs with a normal or increased FRC due to fixation of rib cage in an inspiratory position. 59. Jugular venous distension may be observed on physical examination of acute COPD exacerbation during expiration due to increased intrathoracic pressure. Physical exam often shows wheezing, tachypnea, prolonged expiration, and use of accessory respiratory muscles. 61. What chest X-ray finding may be found on patients with COPD? Hyperinflation with flattening of diaphragm, greater than 8 ribs counted equals hyperinflation. What physical exam finding does this produce? Distant heart sounds listen at subxiphoid process. 62. What antibody is most commonly seen in granulomatosis with polyangiitis? Vaganers. CANCA also called proteinase. CANCA 90%, PANCA, and POANCA 20%. Treatment: cyclophosphamide and corticosteroids. 63. What is the complication seen in men with cystic fibrosis? Infertile sperm transport problem due to bilateral absence of vas deferens. Can they still reproduce? Yes, as they can make sperm, so they're eligible for IVF. 64. Ventilator-associated pneumonia is a type of hospital-acquired pneumonia that develops after more than 48 hours of mechanical ventilation intubation. Presentation: Pulmonary infiltrates with one or more of the following: fever, purulent secretions, leukocytosis, difficulty with ventilation. 65. Rapid diagnosis: chronic cough with large amounts of mucopurulent sputum, history of recurrent infections. What is the diagnosis? Bronchitis. High-resolution CT is the current gold standard. 66. Most common causes of chronic cough in non-smoking patient: cough greater than 3 mo. With normal X-ray, GERD, asthma, post-nasal drip, upper airway cough syndrome, or ACE inhibitors use. 67. What is a key differentiating feature in a patient with pulmonary edema for CHF versus ARDS? ARDS has normal pulmonary capillary wedge pressure. CHF, fluid overload, has increased pulmonary capillary wedge pressure. 68. What is the partial O2 divided by fractional inspired O2 ratio? Clinical indicator of hypoxemia. Ratio of O2 tension O2 in blood to fraction of inspired O2 fraction O2 in inspired air, usually 21%. Normal versus ARDS. Normal equals 300 to 500, lesser than 300 is ARDS, 100 is severe ARDS. Calculate. Partial O2 equals 60 mmHg, fractional inspired O2 equals 100% O2, partial O2 divided by fractional inspired O2 equals 60 mmHg equals severe hypoxemia. 69. V. Q is higher at the apex of the lungs and lower at the base of the lungs. Now, significant differentiation between ventilation at apex and base perfusion: Q is higher at the base of the lungs. V divided by Q equals decreased V, Q at base. 70. Which lung cancer is most commonly associated with PTHRP? Squamous cell carcinoma. Differential diagnosis: small cell SIADH, ectopic ACTH, Lambert-Eaton. 71. What is the classic chest X-ray sign for miliary tuberculosis? Diffuse, reticulonodular pattern, millet seed appearance. 72. Rapid diagnosis: what is likely cause in patient with elevated PaCO2 and a normal A gradient? Hypoventilation. 73. Rapid diagnosis: increased breath sounds, increased tactile fremitus. Consolidation: lobar pneumonia. 74. What are the 2 interventions to improve mortality and delay progression of disease in COPD? 1. Smoking cessation. 2. Long-term oxygen therapy. PO2 lesser than 55 or O2 sat lesser than 88. If O2 sat is fine, then O2 is not indicated. MTB says pneumococcal and influenza vaccines decrease mortality. UWORLD says they just decrease the rate of COPD exacerbations. 75. What is the classic triad of invasive aspergillosis in neutropenic patients? Fever, hemoptysis, pleuritic chest pain. What finding will be found on imaging? Pulmonary nodules with halo sign. Nodules with surrounding ground glass opacities reflects hemorrhage around the nodule. 76. Parapneumonic effusions are pleural effusions that form in space adjacent to pneumonia. What are the 3 types? Uncomplicated and complicated. Parapneumonic effusion, bacterial invasion, NBME pus in pleural space. An uncomplicated parapneumonic effusion forms when lung interstitial fluid increases during pneumonia and moves across the adjacent visceral pleural membrane. The pleural fluid is characterized by exudative chemistries and an influx of neutrophils into the pleural space. A complicated parapneumonic effusion develops when there is bacterial invasion of the pleural space. Bacterial invasion typically leads to an increased number of neutrophils and the development of pleural fluid acidosis, which results from anaerobic utilization of glucose by the neutrophils and bacteria. In addition, lysis of neutrophils increases the lactate dehydrogenase concentration in the pleural fluid to values often in excess of 1000 IU/L. 77. Rapid diagnosis: fever, cough, sputum production, and negative chest X-ray preceding an upper respiratory infection. Bronchitis. 78. What are the etiologies for pleural effusion with high lymphocyte count greater than 50%? Cancer, tuberculosis, fungus, high lymphocyte count with high adenosine deaminase. Tuberculosis. 79. Rapid diagnosis, reduced FEV1 divided by FVC, normal DLCO chronic bronchitis. Asthma. 80. COPD results in decreased elasticity of the alveoli, causing a decreased collapsing pressure created by the lungs to expel air. Hence there is air trapping. 81. 2 cm solitary pulmonary nodule, irregular borders, 20-pack year. Next best step, surgical resection. Low risk, so monitor with CT. 82. Rapid diagnosis, dullness to percussion, increased breath sounds, increased tactile fremitus. Lung consolidation. 83. How would you interpret the following thoracentesis pleural fluid sample? Pleural to serum protein ratio is 0.64, pleural to serum LDH ratio of 2, pleural LDH greater than 2 out 3 upper limit of normal of serum LDH. The pleural serum protein ratio is 0.64, which is higher than 0.5, indicating abnormal levels of protein in the pleural fluid. The pleural serum LDH ratio is 2, which is higher than 0.6, indicating abnormal levels of the enzyme LDH in the pleural fluid. The pleural LDH is greater than 2 out of the upper limit of normal for serum LDH, again indicating abnormal levels of LDH in the pleural fluid. The pleural fluid is exudative, meaning it is thicker and stickier than normal fluid and contains higher levels of proteins and other substances. 84. Consolidative pneumonia causes an intrapulmonary right to left shunt due to perfusion in the absence of ventilation. Is hypoxemia corrected with supplemental O2? Though in practice, you will see some improvement. 85. 4 most common causes of chronic cough: upper airway cough syndrome, postnasal drip, asthma, GERD, AC inhibitors. Read questions stem closely to differentiate between the 3. 86. Rapid diagnosis, chronic cough, worse at night, relieved with chlorpheniramine. Postnasal drip, upper airway cough syndrome. 3 causes of chronic cough: postnasal drip, asthma, GERD. Chlorpheniramine is H1 antihistamine that blocks action of histamine to reduce allergic response. 87. Hemoptysis in pulmonary embolism is a result of pulmonary infarction. This will appear as a wedge-shaped infarct on chest CT. Small arrows is a pleural effusion. Large areas is wedge-shaped infarct, Hampton hump. 88. Rapid diagnosis, wedge-shaped infarction on chest CT. Pulmonary embolism. 89. Common pathologic findings in the anterior mediastinum include thymoma, enlargement of the thyroid gland, teratoma, terrible lymphoma. Common pathologic findings in the middle mediastinum include bronchogenic cysts, aortic aneurysms. Common pathologic findings in the posterior mediastinum include neurogenic tumors such as neurofibroma and schwannoma. 90. How can imaging differentiate between aspiration pneumonitis and aspiration pneumonia? Aspiration pneumonitis will show infiltrates acutely on chest X-ray. Aspiration pneumonia will take days to develop. 91. Rapid diagnosis, older persons present with weight loss and facial fullness, face and arm edema, and anterior chest venous engorgement. What is the next best step in management? Chest X-ray, SVC syndrome due to malignancy. 92. What is a complicated parapneumonic effusion? A parapneumonic effusion is any pleural effusion that is secondary to pneumonia, a lung abscess, or another viral or bacterial infection of the lungs. What are the following values typically seen in a complicated parapneumonic effusion? pH low. This is due to acidosis, which occurs when white blood cells called PMNs invade the pleural space and produce acid. Glucose, lesser than 60. This is because PMNs and bacteria in the pleural space can consume and utilize glucose. WBC, greater than 50,000. This is a response to infection and indicates the presence of a large number of white blood cells in the pleural fluid. 94. Rapid diagnosis, patient presents with the following. What is the next best step in management? Chest X-ray clubbing or hypertrophic osteoarthropathy, most common with adenocarcinoma. Most common causes of secondary clubbing are lung malignancies, cystic fibrosis, and right-to-left cardiac shunts. 95. Rapid diagnosis, shipyard workers or insulators, reticulonodular process in lower lobes with pleural plaques. Asbestosis. 96. What is the initial workup and management of a patient with suspected pulmonary embolism? The first step depends on the patient's Wells score. If the Wells score is greater than 4, the initial treatment should be the administration of heparin before the diagnosis is established. If the Wells score is less than 4, the first step should be a D-dimer assay. If the Wells score is greater than 4, what is the next step in the workup and management of a patient with suspected pulmonary embolism? If the Wells score is greater than 4, the next step is to obtain a CT angiogram of the pulmonary arteries to confirm or rule out the diagnosis of pulmonary embolism. If the Wells score is less than 4 and the D-dimer assay is positive, what is the next step in the workup and management of a patient with suspected pulmonary embolism? If the Wells score is less than 4 and the D-dimer assay is positive, the next step is to obtain a CT angiogram of the pulmonary arteries to confirm or rule out the diagnosis. If the D-dimer assay is negative, further testing or observation may be necessary to determine the cause of the patient's symptoms. 97. What position should a patient with massive hemoptysis be placed? Bleeding lung in the dependent position. Lateral position, massive hemoptysis. 1. Put the patient in dependent positioning on one side of bleeding. 2. Secure airway. 3. Stabilize. 4. Stop bleeding bronchoscopy, embolization. 98. What is the most likely diagnosis in a patient with weight loss, cough, hemoptysis that has ptosis that gets better after 1 minute of upward gaze? Lambert-Eaton secondary to small cell carcinoma. Antibodies to presynaptic calcium channels. 99. Rapid diagnosis older smoker presence with hyponatremia, moist mucous membranes, no signs of JVD. SIADH produces euvolemic hyponatremia. SCC of the lung. SIADH is seen with pulmonary pathologies, and patients with HIV are particularly prone to, for example, patient with possible pneumocystis pneumonia develops euvolemic hyponatremia. 101. Before performing thoracentesis for a pleural effusion, if CHF is likely etiology, perform diuresis with furosemide. Then if that fails, perform thoracentesis. Can quickly determine CHF by BNP level. Greater than 500 indicates CHF. 102. What are the tests indicated in the workup of asbestosis? Chest X-ray shows bilateral infiltrates affecting lower lobes. 50% have pleural plaques. Biopsy will show ferruginous bodies. Complications of asbestos. Mesothelioma, bloody exudative pleural effusion, pleural thickening. Bronchogenic carcinoma, most common malignant complication. 103. What is the next best step in a patient with a Wells score of 6? The score is greater than 4. It is likely that the patient needs immediate anticoagulation treatment. If the score is less than 4, a D-dimer test should be done. If the D-dimer test is greater than 500, it's a positive test, so obtain a CT angiography. If the D-dimer test is negative, the patient can be reassured that immediate treatment is not necessary. If it is unlikely that the patient needs immediate treatment, diagnostic testing should be done first. 104. Rapid diagnosis. Chronic renal failure patient underwent treatment for hypertensive emergency and now presents with altered mental status and lactic acidosis. Cyanide toxicity secondary to nitroprusside. Treat with hydroxycobalamin, sodium thiosulfate, sodium nitrate. 105. Pulmonary arterial hypertension is a common manifestation of systemic sclerosis that results from intimal hyperplasia of the pulmonary arteries, differentiated from pulmonary hypertension due to lung disease or left-sided heart failure with normal FEV1 and FEV1 to FVC ratio. 106. The peak airway pressure is the maximum pressure measured as the tidal volume is being delivered and is determined by the airway resistance in the lungs. For example, if there is a problem with the airways like bronchospasm, retained secretions, mucus plug, biting endotracheal tube, there will be a high peak pressure. 108. An elevated peak pressure and a normal plateau pressure indicates that there is an airway issue. For example, if there is a high peak pressure, then it is an airway issue. Peak pressure is determined by airway resistance, so if there is a problem with that, peak pressure will rise. 110. The plateau pressure is measured during an inspiratory hold maneuver and is determined by the compliance of the lung. For example, if there is a problem with compliance, plateau pressure will rise. Elastic pressure is inversely related to compliance, so decreased compliance causes a higher elastic pressure. 112. A thoracentesis of an exudative pleural effusion with a glucose level lesser than 30 mg divided by DL should narrow the differential to rheumatoid palsy or emphysema. 113. What is the modified Wells criteria for the following? The modified Wells criteria is a tool used to determine the likelihood that a patient with suspected deep vein thrombosis or pulmonary embolism actually has one of these conditions. Plus 3 points. Clinical signs of DVT or PE, such as swelling or pain in the leg or chest, respectively. An alternate diagnosis is less likely than DVT or PE. Plus 1.5 points. Previous DVT or PE. Heart rate greater than 100 beats per minute. Recent surgery or immobilization. Plus 1 point. Hemoptysis, cancer. The scores are added up and used to determine the likelihood that the patient has DVT or PE. A score of 4 or higher suggests a high likelihood of DVT or PE, while a score of 3 or lower suggests a low likelihood. 115. What is the next best step in a patient with a modified Wells score lesser than 4? D-dimer, diagnostic test to evaluate for before anticoagulation. If greater than 4, anticoagulate before diagnostic testing. 116. What is the likely diagnosis in an inmate who smokes in presence with rapidly worsening shortness of breath, tachycardia, tachypnea, and 87% O2 sat? He is poorly adherent to his asthma medications and began taking ibuprofen for shoulder pain the previous night. Urticarial rash is seen over the trunk and extremities. Anaphylaxis, laryngeal edema. Anaphylaxis may be confused with an asthma exacerbation if skin involvement is minimal or missed by the clinician. NSAIDs can worsen anaphylaxis. 117. Patients with acute asthma exacerbation will generally demonstrate respiratory alkalosis, partial CO2, and pH. If these values begin to normalize, this is a sign of respiratory failure. Patients with asthma exacerbation hyperventilate, which should lead to low CO2, thus should be alkalotic. A normal or elevated partial CO2 suggests impending respiratory failure, inability to meet increased respiratory demands. 118. A lobectomy is the standard approach to surgical management of lung cancers and can be tolerated if the FEV1 greater than 1.5 liters and DLCO greater than 60%. 119. What is the next step in management in a patient with massive hemoptysis and dyspnea on exertion who is stabilized? X-ray shows hyperinflation with a 2 cm nodule in the right lower lobe. The patient is placed in the right lateral decubitus position. Bronchoscopy initial steps involve repositioning, airway protection, and cardiovascular support. After stabilizing, coagulation parameters should be controlled. Then locate the source of bleeding. Bronchoscopy. 120. When should intubation be considered in patients with COPD or asthma exacerbation? Profound acidemia, pH lesser than 7.1, poor mental status, somnolence, lack of cooperation, hemodynamic instability otherwise. Begin with initiation of non-invasive positive pressure ventilation in patients with respiratory failure. Endotracheal intubation with mechanical ventilation is recommended for patients who fail a trial of NPPV. 121. What is the most likely diagnosis in a patient with a past medical history of stable angina who presents with difficulty breathing and wheezing? His recent history is notable for visiting his ear, nose, and throat doctor for persistent nasal blockage. Aspirin exacerbated respiratory disease pseudoallergic reaction. Assume the patient was taking aspirin for his stable angina. Most often seen in patients with a history of asthma or chronic rhinosinusitis with nasal polyposis. Remember, this is age independent. 122. Giving supplemental oxygen to patients with advanced COPD can worsen their condition of hypercapnia because it causes changes in the way their lungs function, including a reduction in the ability of the blood to carry carbon dioxide and a reduction in the amount of air that can enter the small air sacs in the lungs. Patients with COPD have a chronic failure of their respiratory system and are used to having high levels of carbon dioxide in their blood. Therefore, giving them supplemental oxygen can decrease their breathing rate, leading to an increase in the amount of carbon dioxide in their blood, causing hypercapnia. 123. The mainstays of pharmacologic treatment for classic COPD includes inhaled bronchodilators such as antimuscarinic agents and beta agonists, and inhaled steroids. SABA and ipratropium or tiotropium are used initially, but inhaled steroids and LABA can be used for patients with more severe COPD. 124. Aspiration pneumonitis occurs hours after an aspiration event and the treatment is supportive. 125. What PFTs are characteristic of idiopathic pulmonary fibrosis? Decreased total lung capacity and normal FEV1 to FVC with decreased DLCO. 126. What are the indications for placement of an IVC filter? Patients at risk of pulmonary embolism who have contraindications to anticoagulation, thrombolysis, and thrombectomy. 127. What is the next best step in management of a patient with suspected DVT, who also has a 2-day history of bright red blood per rectum and evidence of a diverticular bleed? IVC filter. 128. Aspiration pneumonia prophylaxis can include oral care, diet modification for patients with dysphagia, and elevating the head of the bed to 30 to 45 degrees. 129. What is the next step in management for a patient with acute COPD exacerbation with continued symptoms despite medical management? Patient is dyspneic and lethargic. ABG shows a pH of 7.08. Intubation non-invasive pressure ventilation is contraindicated if the pH is lesser than 7.1. Severe acidosis intubate. 130. What is the most likely diagnosis in a patient who presents with a week of fever, dyspnea, and a cough with productive, foul-smelling sputum? She recently underwent an endoscopy 10 days ago. Aspiration pneumonia. 131. What is the best treatment for a patient who presents with a week of fever, dyspnea, and a cough with productive, foul-smelling sputum? She recently underwent an endoscopy 10 days ago. Clindamycin. 132. What is the most likely diagnosis in a patient with extensive smoking history, CAD, and hypertension who presents with 1-week history of exertional dyspnea, bilateral lung crackles, and occasional wheezes? ABG shows respiratory alkalosis. Congestive heart failure CHF will have respiratory alkalosis. Pulmonary edema reduces ventilation, causing tachypnea, leading to loss of CO2. COPD will have respiratory acidosis and widespread wheezing. Pulmonary embolism is acute onset. 133. Chronic pulmonary aspergillosis is seen in immunocompetent patients with a history of pulmonary disease, cough, hemoptysis, and shortness of breath. 137. The features of chronic pulmonary aspergillosis include cough, hemoptysis, and fatigue, seen in patients with underlying lung disease versus invasive aspergillosis which has hemoptysis plus fever, chest pain. 138. What are the key features of invasive aspergillosis? Hemoptysis plus fever, chest pain. Both chronic pulmonary aspergillosis and invasive aspergillosis will have hemoptysis. 139. What will the pulmonary examination findings show in a patient with the following X-ray in a patient with a history of breast cancer? Vitals are within normal limits. Breath sounds, decreased tactile fremitus, decreased percussion. Dull X-ray findings in pleural effusion show blunting of the costophrenic angles. Fluid pleural effusion and air pneumothorax will insulate sounds and vibrations originating from the lung, leading to decreased breath sounds and decreased tactile fremitus. Dullness to percussion occurs due to an increase in tissue, fluid density compared to normal air-filled lung tissue. 140. What are the two causes of hypoxemia with a normal EG gradient? Reduced PiO2, high altitude, and hypoventilation.